you block the synthesis of the purine, then which cells would be the most burden? The ones which are also deficient in the other limb of the synthesis, that is the salvage pathway, that is the hematological cells. That's why the hematological malignancies, they respond much better to cytarabine than the others. Okay? Okay, so let's see what is DHFR. Well, this is a single slide which shows you the mode of action of two drugs. Okay, and gives you an idea that why sometimes it's not a good idea to mix two drugs. Okay, because they are pretty similar in their spectrum of activity, and then they would add to the adverse effects. Okay, so DHFR or dihydrofolate reductase is an enzyme. You know, the folic acid when enters the cell, it readily gets out of the cell. To capture it within cell, there is a tail which is attached to it. Okay, so this is yes. Sorry. No, the glutamic acid. Okay, so glutamic acid is added to it. Multiple molecules of glutamic acid are added to the folic acid, so it becomes a polyglutamate tail. Okay, so folate receives a tail. Okay, now polyglutamate, this folic acid then undergoes reduction. Okay, by transferring two hydrogens, it becomes reduced folic acid, and this is further reduced to tetrahydrofolic acid. Okay, another two. Okay, so both these reactions are brought about by folate reductase, dihydrofolate reductase. So both these reactions are brought about by the same enzyme. Okay, it's a stepwise reduction brought about by the same enzyme, and then the folic acid being reduced folic acid is now the active folic acid, which then takes part in one carbon metabolism, like transfer of methyl groups, transfer of carbonyl groups, transfer of formyl groups, things like that. Okay? Okay, so if you remember, one example of one carbon transfer is synthesis of purines. Yeah? From the de novo synthesis of purines. If you remember, certain amino acids and carbon dioxide and folate, all of them, they take part to form the double rings of the purines. So one example is that. Okay, methotrexate inhibits DHFR, so it actually deprives the cell of folate. Now, DUMP is the deoxyuridylate, which is a precursor pyrimidine. Okay, it's a precursor of pyrimidine. You know purines and pyrimidines?
Yes, of course.
Yeah. So the precursor of purines is
T and
inosine. Yeah, IMP, inosine monophosphate. Okay. Whereas the uridine monophosphate and orotic acid monophosphate, orotate monophosphate, OMP and UMP, they are the precursors of the pyrimidines. Just a repetition of your previous biochemistry. So DUMP is the deoxyuridylate or uridylic acid, monophosphate. Okay. So DUMP, please, is converted to thymidylate, DTMP. Okay, by transfer of a moiety with the help of reduced folate, and the enzyme involved is thymidylate synthase. So now, which is the drug which blocks
5FU.
5FU. Good. Mayor. Okay, so the third group. So now, one example of how two drugs, when given together, will add up to the same effect and will add up to the adverse effects. So you know that all the chemotherapy is prescribed as a combination of multiple drugs. Okay? So try to avoid combination of those drugs which have a similar mode of action.
But what is the similar mode of action?
One carbon-metabolism. Yeah.
Like if I use the methotrexate, there will be no products for the fluorouracil block.
Yes.
So you use it, but it won't give
When you combine the drugs, it's a very good question. When you combine the drugs in anti-cancer regimen, okay, you pick and choose from the drugs which have a different modes of action, because the cancer cells what is the use of trying then that we couldn't understand a single word while getting through the book if you don't listen? This lecture is just to give you an idea how to get most of the benefit from your books. So please be attentive. Okay. So when you combine drugs in anti-cancer therapeutic regimen, you combine the drugs based on the difference in their mode of action, differences in their side effect profile. Okay, but the first and foremost important is the difference in the mode of action, because cancer cells are pretty smart in terms of repair, and they can, if you give them a single mode of action drugs or similar mode of action drugs, it's highly likely that the resistance will emerge. Okay, so there is a multiple mode of action approach, so that there are lesser chances of the emergence of resistance. The cancer cells are pretty notorious for emerging the resistant strain. Okay, so agents from the natural resources. Now this is a third group, and you can see it has 4 drugs here and a few more in the next slide. So doxorubicin and daunorubicin, we will concentrate here first. They are both anthracyclines. Anthracycline, now this is a chemical group, a name which probably you need to remember. Anthracycline, because there are a number of drugs in anthracyclines, and a lot of things are shared by them as a group. So sometimes when you are studying a book or a text, they just can refer anthracyclines. Okay, because all of them, they are similar in that context. So anthracycline means what? Doxorubicin, daunorubicin, idarubicin, epirubicin. Okay. But for your drug list, there are just 2, doxorubicin and daunorubicin. So the mode of action is intercalation, okay, within DNA. Now intercalation and alkylation, okay, they are, to begin with, when you start with it, they pretty look the same, but they are not the same. Intercalation is a non-covalent interaction, okay, whereas the alkylation is a covalent interaction, okay. Plus, they also bring about free radical injury. They generate lots of the toxic radicals, which also produce the therapeutic benefit. So the acute toxicity is nausea, red urine with doxorubicin and daunorubicin, and cardiotoxicity. Now cardiotoxicity is one peculiar adverse effect of this group, as a group, all of them. But doxorubicin is more notorious for this. Okay? And the cardiotoxicity could be either acute or chronic. Okay? That's why in a cardiac patient, you prefer not to prescribe doxorubicin.
What about donor?
Okay? When I'm emphasizing something, that's probably the secret of the business. Okay? So cardiotoxicity, the delayed cardiotoxicity is mainly cardiomyopathy, congestive cardiac failure. The acute cardiotoxicity is mainly cardiac arrhythmias.
What is donor?
Okay? So the major uses in cancers of breast, Hodgkin's lymphoma, non-Hodgkin's lymphoma, ovarian cancers and lung cancers. Whereas daunorubicin is in myelogenous leukemia and lymphogenous leukemia, acute. Now, what is the reason? That's not understood why it has got a preference for the hematological malignancies. So again, cardiotoxicity, alopecia, myelosuppression, they are the ones which are more common with daunorubicin, whereas with doxorubicin is cardiotoxicity, which is the major one. Okay? So paclitaxel is a taxane. Sometimes, taxane by another, by default, you need to remember this as a taxane, paclitaxel, docetaxel, because there are some groups which share many features, a lot of features amongst them. So just like anthracyclines, taxane is another example. Sometimes a medical text just can refer. The taxanes are effective in this. Then you need to understand that paclitaxel and docetaxel. Okay? But for your drug list, it is paclitaxel. Okay? The famous Taxol. Okay? It's the brand name, Taxol. It blocks microtubule disassembly. Okay? Microtubules have got a positive end and a negative end. We will see in the next slide. So disassembly. Nausea, vomiting, allergy, and cardiotoxicity, they are the acute toxicities, and myelosuppression and neuropathy is the delayed side effect. Now, why neuropathy? Could someone explain when you talk about microtubules? Neuropathy.
Neurotransmitter release.
Exactly, because the transport of the axonal transport mechanism for neurotransmitter synthesized in the cell body of the neuron travels to the axonal ends on microtubules. Okay, so if the microtubules are affected, the transportation of the neurotransmitter would also be affected. That's why neuropathy. Okay, the uses, main uses are breast, lung, ovary, gastroesophageal, head and neck, the common cancers. Vincristine are the vinca alkaloids. There are vincristine, vinblastine, and vinorelbine. Okay, inhibits beta-tubulin polymerization. The acute toxicity is minimal at standard doses, but the delayed toxicity is neuropathy, again, understandable, tampers with microtubule. We'll see what is the difference between these two in terms of the microtubule inhibition. Neurotoxicity, alopecia, and SIADH, syndrome of inappropriate release of ADH. Okay, so it's a hyper secretion of ADH. Okay, and you know what is ADH? Antidiuretic hormone. Okay. So major uses in cancers of ALL means acute lymphocytic leukemia, HL is Hodgkin's lymphoma, NHL is non-Hodgkin's lymphoma, neuroblastoma. Okay. Now let's see what is intercalation, and then we will also see what is the difference between the microtubule affecting drugs. Now this is intercalation. The drug, doxorubicin, just physically enters the two strands and sits there. It's a sit-in, okay? Just like a sit-in protest, okay? Just like a sit-in in front of an office, just a sit-in protest. So it just goes and sits in. That's it, okay? It's a non-covalent interaction, so could be reversed, okay? And could be reversed chemically. Intercalation is a chemical term rather. So in chemistry, we can get rid of these reactions chemically or thermally. Okay. So what it does when it just sits in, because it sits in, it blocks the pathway for movement of DNA polymerase. Okay. So DNA polymerase cannot work. Okay, so effective DNA replication stops.